So good evening, everybody. Thank you, Shannon and Jason, for the invitation. I think it's great to see some very familiar faces in a different venue after hours, where I'm hoping we can have a real interactive town hall type format where we can interact not just with myself as a representative of the surgical side of your treatment team, but with all the other very important, vital cogs in the chain in terms of head and neck care delivery at the Odette. So in terms of who we are, I like to think that we're the little engine that could. We are a cancer center here in the city that is somewhat eclipsed by the big brother south of Bloor Street, which is Princess Margaret Hospital. But we hit above our weight in terms of how many cases we do, how many patients we treat, and the type of care that we embody and like to pride ourselves in delivering. So we're actually the third largest care provider for head and neck issues in the country, after Princess Margaret and after Western University in London. And we do a lot of surgical cases, so about 100 quaternity, which means fourth level, so something that's provided for in the community, say placement of a tube in a child's ear or removal of a tonsil, is considered primary level care. So we, in the province, care is escalated based on complexity, with the fourth level being sort of the highest level of care delivery. And the types of problems that many of you present with are actually some of the most complicated, based on the number of systems involved, based on the type of anatomy that's involved in all of cancer care that's delivered here in the province. So something that I do, now this is a patient who has had a major surgery. So this is a patient who has had a cancer involving their oral cavity, which is basically anywhere from their lips to the back of their tongue, who has had a removal of not just the cancerous tumor, but also surrounding structures, which in this situation is the tongue, the floor of the mouth, as well as a portion of the lower part of the jaw called the mandible bone. And we've actually transplanted a portion of this patient's leg bone called the fibula bone with some skin and as well as an artery and vein. And using carpentry skills, we've shaped that straight bone into a curved structure to actually reconstruct the lower arch of the jawbone or mandible. And so that's only part of the process. So we do the surgery, we do a lot of the technical aspects, but then there's everything else. It's the radiation, it's the support through dietary, through occupational and physical therapy during the hospital, after the hospital stay, the interaction with the nursing team. That's really what I want to highlight tonight. Something I'm very proud of, though, is we're evolving. In my 13 years on staff, we've taken from simply taking a patient like this, where before we would just put a metal bar in and the patient would be left with no bone. And the problem with just putting a piece of metal in is that over time, the screws that hold that plate in place, or the metal itself, fatigues, and then the plate either loosens, fractures, or works itself out through the skin, creating more problems subsequent to the original. So not only have we been able to step beyond those types of problems, but now with our colleagues in dentistry and oral maxillofacial surgery, I'm proud to say we're actually the home of the largest dental osseointegrated program in the province. We actually take special screws called osseointegrated implants, and we're able to sync special, basically new platforms for holding a bridge. So we're able to take a patient who's had their tooth-bearing portion of their lower jaw, remove it, put a new piece of bone in that has its own blood supply, is able to sustain normal healing through radiation and chemotherapy delivery, and then bring them back to dental rehabilitation such that they can chew, they can speak, they can smile in public, they can eat a piece of wedding cake without fear of any issues, without spillage of foodstuffs, and their denture becoming loosened, etc. So moving forward, in terms of the volume, now you have all painfully suffered from waiting in the waiting room while your time ticks away, you paid for parking, and you're wondering, why am I booked at 10 o'clock and I'm not being seen till 11:30? And that's simply because the complexity of the problems, there's a lot of patients to be seen by many different doctors all at once. So in terms of the new cases, so if you've come in the afternoon when you were first diagnosed, we see between 200 and 300 new patients per year. But you have to remember, this is seen on one afternoon a week. So this isn't every day. This is one afternoon a week over the year. And interposed amongst that, we're seeing upwards of 1,300 to 1,500 follow-up patients. So there's a reason why you're waiting. It's not that we don't value your time. It's simply that the work is growing. You know, as part of our care pathway, we're becoming more inundated with referrals. We're getting busier. And unfortunately, the physical plant, the number of doctors and nurses and ancillary staff is somewhat limited. So I'm sure we'll be speaking about that in the town hall, because it's something we do want to improve, and we want to become better at delivering care. So in terms of who we are, you've seen us on Tuesdays. So Tuesday is the head and neck day at the Cancer Center. So the mornings are dedicated to follow-up visits. The afternoons are dedicated to new patient consultation. As well, as a result of that baseline platform, we've started to scale up our care delivery based on need. So we've started to develop satellite radiation review clinics. We've developed procedure clinics where instead of taking people to the operating room, exposing the patient to excess length of waiting times, we're actually able to often deliver biopsies, lymph node excisions, skin cancer delivery within 1 month from initial diagnosis to final completion of treatment. So that's an amazing acceleration of care, and that's something that we're immensely proud of. As well, we've developed a vocal cord injection clinic. So what that means, and I'll show a picture of it, that basically allows us to, for folks who have vocal cord palsy and are talking very weak and breathy and are having issues with swallowing because their vocal cords are not coming together when they're speaking. They're not coming together to protect their airway when they swallow. And as a consequence, are choking when they swallow, for instance, thin liquids, or they're talking in such a whisper that they're not able to be heard above a very low baseline. And we're actually able to rehabilitate their voices to about 80 to 90% of baseline strength with a simple injection delivered as an outpatient. So we also, as part of your care pathway, it's not just seeing Higgins or Poon or Lee or an epicetus. You're actually seeing everybody. You may not know that, but every time you have a new clinical diagnosis and a treatment plan is being thought about, your case is being discussed by everyone involved. So every first, third, and fifth Tuesday afternoon between 1 and 2, we have a discussion called a tumor board where your imaging is reviewed by the radiologist, the pathology is reviewed by the attending head and neck pathologist, who is a new recruit from Memorial Sloan Kettering in New York. So it also speaks to the team that we're starting to build up. But also the radiation specialist, chemotherapist, and then everybody else, everybody in this front row. So it's not just 1 or 2 people, everybody inputs into your care. So we've lost some faces. Some of you may have been former patients of Judith Ballag or Bob McKenzie, and they have gone on to different things, new pursuits in their retirement, but we've grown, and we've some exciting, vibrant direction that we are going, and that's a result of some of the new people that we're bringing on staff. Irene Karam, Justin Lee, Kelvin Chen. From when I started, we've basically grown in number by over 3 frontline clinical care staff in either radiation oncology, surgery, or medical oncology. And I'm pleased to say that we're going to be recruiting another surgeon we're hoping that they are able to start for fall of 2017. So we are growing. The team members, so Kevin Higgins, we have Dan and Epictetus and Jean Davidson. Radiation oncology is represented by Ian Poon, Justin Lee, and Irene Karam. In medical oncology, we have Simran Singh and Kelvin Chan. The speech-language pathology, Marlene Jacobson will be joining us later, as well as Joanne Gray, who many of you interact with routinely. Sean Gray is our nursing lead and is going to speak to us about some of the many issues that the nurses face in head and neck care. We have a database manager and researcher such that we're always compiling information such that we can do better. We can learn from the clinical encounters. We're very active in research, and I'm very proud of that we're trying to develop improved clinical practice and drive the process forward. We have Elaine and Edith, who are here tonight, Leslie Gibson, and then we also have a very strong working relationship with our medical psychiatrists, our palliative care physicians, our addiction medicine physicians, because we know that there's a lot of issues that are related to our head and neck population, including very profound and powerful addictions to nicotine, to alcohol. We have issues with sleep. We have issues with body image. We have sexual issues in terms of survivorship, how I am, how do I feel, how do I look, that are beyond a simple surgeon. And we know that we've got to treat the whole person, not just remove a cancerous jaw and rebuild it. That arguably is probably the simplest part of this whole procedure. And that's what we're hoping to highlight today. So a couple more slides, because I really want to focus on some of the other folks here who are on the front row. And how I want to encourage some of the folks in this audience. Because one of the things that I ask all of my patients is that when we treat you, it's a partnership, it's a collaboration. We do our best to get you to cure. The expectation that we have, and that I have personally, is that you guys become survivors, but survivors who are ambassadors. It's not just about you, it's about raising awareness. It's about asking your family member to seek help for smoking cessation. It's about helping that family member or relative or friend of a friend to look at that spot on their skin or go to their family doctor and have a skin check, because that small little brown spot is actually a melanoma that has been sitting there for some time. So it's ambassadorship. Fundraising is one piece. So if those who have means, we obviously would love it if you can assist us, because a lot of the groundwork that I'm going to speak to, a lot of the advances, we all know these are tough times in the province, in the Ministry of Health. This is not the time where we're getting a lot of Ministry of Health dollars to help with novel techniques, with novel equipment, with novel approaches. So that's where fundraising helps. So that's my appeal. I want you to be ambassadors. If you can donate and you're donating to other causes, think about helping the head and neck site group such that we can do more, and often do more with far less than other cancer centers. So some of the highlights of what we're doing. So we talked about this vocal cord injection. So basically what this is using a telescope that is able to go through the nose all the way down into the stomach with anesthesia to freeze the nose, to freeze the back of the throat, such that before, when somebody came in with a cancerous lymph node in the neck, and we weren't sure where it was coming from. Was it coming from the mouth? Was it coming from the back of the throat? Was it coming from the base of the tongue, the tonsil? We would have to put those patients on an operating room list, wait several weeks in order to give them a general anesthetic that they would have a hangover from the drugs relating to the induction of anesthesia. They would have an invasive procedure, they would stay overnight, then they would go home, and it would take another few weeks to get the diagnosis. Where's the cancer coming from? Where do you care? Why do you care? Well, if you don't know where the cancer is coming from, how are you going to treat it with radiation? How are you going to treat it with targeting? Our radiation has come a long way. It's just like, you know, laser-guided bomb versus mass carpet bombing. You go from a very broad area where lots of other tissue that is innocent is affected, and affected in a negative way, to a very honed-in, precise delivery. So back to how this matters and how this ties in. So before we'd put people to sleep, now we're able to freeze their nose, freeze the back of the throat, decongest them, put a telescope through the nose, and do biopsies almost same day. So this is where the tie into that procedure clinic that was a bridge, building up on our existing platform of Tuesday clinics. So either Monday afternoon or Friday afternoon, we're now able to do these biopsies, which are called panendoscopies. We're able to biopsy all the suspicious areas almost real time. As an extension of that, those folks who come in who have more advanced tumors or who have had treatment, say, for lung cancer or breast cancer or esophageal cancer and have a weak, breathy voice and are not able to communicate, aren't able to swallow safely, we actually put a long needle through their mouth and are able to inject into the vocal cord such that instead of having a gap, we get that closure, and that closure that's important for speaking and for swallowing safely. Some of the areas that I'm interested in is point of care ultrasound. Some of you who are patients of mine might notice we have an ultrasound machine. So that allows us, instead of seeing or feeling a lymph node or a mass, sending you to the radiologist to do a biopsy, we're able to take the machine, ultrasound you ourselves, and using the ultrasound machine to guide a needle into that suspicious area, which accelerates care, saving 2, 3, 4, sometimes up to 6 weeks in terms of care time. Where we're going with this is we're hopefully going to allow what's called contrast enhanced ultrasounds, which is CEUS, where actually now this slide doesn't project very well, and these just look like ink blots to most people, sort of blurs. But what I want to show you is even the lay observer can see that these look like little light bulbs. So these are little light bulbs that have been lit up by using a contrast agent for ultrasound. And ultrasound, for the women in the room, know all about it. It's sound waves. But the problem is ultrasound never had, if you've had a CAT scan, you know you have an IV and you have something injected such that the blood vessels light up and we're able to differentiate blood vessels from lymph nodes, blood vessels from other structures. We didn't have that up until a year or two ago for ultrasound. So one of the things that we're involved with, and I have a personal interest in, with the Sunnybrook Research Institute, where they're world leaders at ultrasound technology, we're actually using microbubbles, which are literally like an aero bar. It's little bubbles of air that are injected into the bloodstream and are taken up into the lymph nodes. And it's the little bubbles that act as almost like a reflector when you're on your bicycle. And it's what makes this sort of gray smudge look like a much brighter, discernible white light bulb. And that allows us to guide surgery such that we're able to target these lymph nodes much more precisely, real time, intraoperatively. So we're now bringing the radiology suite not only into the clinical arena, but into the operating room. So we're going from 19th and 20th century ways of doing things to the 21st century and beyond. And that's happening here. One of the other areas, now this is a graphic photo, and I'm trying to scan for any laryngectomy patients in the room. This is a patient who's had their voice box removed. One of the issues with that type of surgery is we're separating the shared breathing tube from the swallowing tube with that operation. So there's a physical separation from the airway to the swallowing tube. The swallowing tube then has to be, it's like a clamshell, has to be sutured such that it's continuous. The airway is brought out through the skin, and that's the stoma that you breathe through. But the swallowing tube has to be closed. One of the issues that affects every patient who undergoes laryngectomy surgery is that the blood supply, because most of these folks, or many of them, have had radiation and or chemotherapy, is the blood supply is affected by that treatment. And that suture line, when we've done the separation and that swallowing tube is sutured together, anywhere along that suture line, if the blood supply isn't perfect, you get a little opening, and it's a little blowhole. And you may say, oh, well, that's like if I've cut my hand, I get a little area where it's raw. Well, that might be fine if it's on the outside of your skin. It's an entirely different problem if it's actually your swallowing tube. And you can imagine when you swallow, there's saliva. And if it's not a continuous structure, it actually leaks out into the surrounding structures of the neck, causing potentially life-threatening complication. And one of the things that we're using is this new intraoperative mapping. You can see this sort of ink blot, and this is a special dye that fluoresces. It's excited by a type of laser called a near-infrared laser. And basically what we're seeing here, these are blood vessels in the neck. And you can see this is the same patient mapped with this special laser with dye injection. And all the blood vessels are these big white tubes. But what we're specifically interested in is the blood supply of this remaining back wall of the swallowing tube, the clamshell. Because we've figured out that if you know what the blood supply is along that entire remaining portion of the clamshell, you'll know maybe, well, that area has no blood supply. It needs to be trimmed away, as opposed to putting a suture through it because it looks okay, but in 20 hours or 24 hours, that blood supply will shut down and you'll actually have a leak. So it's allowing us to be predictive in terms of where the complications will be. Why? So we avoid them. So this is a huge area in terms of research interests. So it goes back to ambassadorship. I don't expect everybody to give money to us, but you spread the word. Sunnybrook, they're doing interesting things, but stuff like this requires resources. And all of these projects have been supported not by our Ministry of Health, but thankfully from the foundation. So it's allowing us to really push the initiatives and develop new techniques, which we're very excited about. So this is another picture. This is a patient who's had a major skin operation. This is a big cut that basically comes along the neck down into the chest. And you can see this is all white here. But then down in here, you see it's darker. It's black. This is what happens when that area is not addressed at the time of surgery. This is the same patient. So this is the incision. Just imagine that patient's been rotated and is now lying recumbent or down like this. You can see this black area corresponds with this black area. Well, what is that? That's just a scab. It's more than just a scab. That's a full thickness loss of skin, which now is exposed over this patient's clavicle bone and major blood vessels to the arm. Had we known that at the time, we would have cut that off and brought this skin edge down to this one. Now there's layers of complexity to this patient that are probably beyond discussion here. But this is the type of thing that we're starting to involve ourselves with intraoperatively so we can do better and have better outcomes. Because it's not just me trying to get this patient healed, but there are downstream effects for patients like this. When we have wound issues, that involves more resources. It involves more community care access nursing. It involves more clinic visits, which means more delays for everybody else to be seen because I'm dealing with this complicated wound. But for that patient, not only is there the inconvenience of more nursing care, having to wait around for CCAC or drive to the wound care center, but it's the delay in care to get radiation therapy because that wound is not healed enough. The wound isn't knit enough to allow radiation to be delivered. So you can see that this is a very complicated situation. And anywhere along the line we can intervene, we can do better. This is the last area that I want to talk about for some of the laryngectomy patients. So that picture of the laryngectomy we showed earlier. Before this initiative, which is what's called an HME device, which we just brought into clinical practice a year ago, patients would be dealing with what's called an external humidifier. They basically, during their course in hospital, while they're recovering from surgery, would have this mister, almost like a housing, a plastic housing that would blow humidified air and or oxygen at their neck hole, which is where they're breathing through the neck here. Because when you lose the larynx, you lose a lot of the humidification to the lower airway. That's one of the principal reasons our nose is there, our sinuses are there as anatomical structures, is that they serve to warm the air. They serve to take the air from a relatively low humidity, especially in the winter time where we're indoors with central air, and humidify it such that there's no crusting. So before we started this clinical initiative, patients would have this external collar, almost like a tie, that blew air. But the problem is that they were hooked up to a machine, they were connected to their bed, they couldn't walk around the ward. That predisposed them to other problems like blood clots in the leg, emboli in the lung, pneumonias, wound infections, etc. So we've actually replaced the upper airway humidifier with a special cassette, which is a plastic housing that has a little cassette in that has a sponge that serves as a way of humidifying the air such that it is exactly the same as the patient who was previously hooked up to that external humidifier, with all the advantages of now being completely portable. And we've actually recently published on how this is not only making patients do better, it's shortening their stay in hospital, but it's saving lives. Because one of the problems when you had a patient who had just had laryngeal surgery was if they couldn't cough properly and they couldn't have humidification, their secretions would solidify and get really thick, like a thick crust, almost like a cast. And they'd have to cough it. But their cough would often be weakened because of the surgery they've had. And sometimes they would crust and crust and crust and crust to the point of their openings to their lungs being narrowed and not being able to breathe. So this has effectively gotten rid of that happening altogether. So this is really the end of my stay. I was allocated, 30 to 40 minutes, and I want to stay underneath that. But we talked about this. I'm glad you came. I'm glad you heard the story. You're part of the continuum. You're part of the team. Try and be ambassadors. We can learn a heck of a lot from Terry Fox. The Terry Fox run was just a week or so ago. And every time I see the Terry Fox story, it's hard not to be inspired by that. And that's why I got into cancer care delivery, was that story. And if Terry Fox had been alive today, he'd be alive. He'd be alive with a leg. Because that's how far the treatment has come. So there's hope. And thank you for your attention.